Good evening, and welcome to our first Doctors on Call program of the season. I'm Dr. Ray Christensen from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School Duluth campus. I'm your host for a program tonight on heart problems and high blood pressure. Before we begin, I would like to thank Dr. Ruth Wester and Dr. Alan Johns for their years of hosting this program prior to their retirement. This season, we'll be expanding Doctors on Call to include even more community involvement. This year, Dr. Paula Termulin, Dean of the University of Minnesota Medical School Duluth campus, and I will host half of the programs. The other programs will be hosted by physicians from Community Memorial Hospital Cloquet, Essentia Health, Fairview Hospital Hibbing, and St. Luke's Hospital. As always, the success of this program is very dependent on you, the viewer. Please call in your questions tonight on the diagnosis and treatment of heart problems and blood pressure. We will do our best to address them. The numbers are at the bottom of your screen. Our panelists this evening include Dr. Disha Mookherjee, a cardiologist with St. Luke's Cardiology Associates, Dr. John Wood, a family physician and program director of the Duluth Family Practice Residency program, and Dr. Nicole Worden, a cardiologist with Essentia Health at St. Mary's Heart and Vascular Center. Our students answering the phones tonight are Jacob Bentley of Austin, Minnesota, Casey Riley of Worthington, Minnesota, and Alec Rudstrom of Brainerd, Minnesota. And now, on to tonight's program and the year 37, actually, of Doctors on Call.
Oh my goodness.
It's been a long time.
Yeah, it's a long time.
I believe 1982, Dr. Bolger told me.
Wow.
It's older than me.
They had TVs back then. Oh
It's
boy.
not older than me.
Not older than me.
No, it's not. You and I are.
Yeah.
So, John,
Right.
as the family doc here, what are the current guidelines? We might as well start out with blood pressure because that came up and there's
Sure.
been a lot of discussion on blood pressure lately. What are the current guidelines for the treatment of blood pressure as far as numbers?
Well, there's been I'd say, fair amount of controversy over the past few years, but I think things kind of settled out over the past year and make it a little simpler. First of all, I think everyone pretty much agrees across every specialty now that, in my mind, 120/80 is a good number to shoot for. That's basically the diagnosis of hypertension anyway. If your blood pressure is above that and you're undiagnosed and it's over 120/80, you do have hypertension. And there's obviously certain categories, depending on how far you go up, certain numbers are relevant. But in terms of the overall, if you want to think of a number and leave this program with a number, you think of 120/80 for all, people with heart disease, people with diabetes, people with renal disease. You just keep it simple. There are certain subsets. Maybe we can make it more complicated, but I don't think that's really worth it for today. And most hypertension is primary hypertension, meaning there's no real cause. It's just you have high blood pressure.
Because I wasn't listening carefully, is there an age differential?
There is and there isn't. In my mind, there really isn't, but in some people's mind, there is. Like there's a certain JNC8, certain study that said 150/90 was a goal you wanted to get below if you're over 60 or under 60. But in my mind, that was basically refuted by the American College of Cardiology, the American Heart Association. And there was a trial in the New England Journal of Medicine about 6 years ago that basically said that if you compared 140 over systolic of 140 versus systolic of 120 for people without diabetes, that if you got that blood pressure down to 120, there was a 25% reduction in mortality. So in my mind, that's worth shooting for. So that's kind of where I'm coming from.
So that doesn't mean that everybody needs medication, of course.
Yeah.
That just means that you need to pay attention to what the blood pressure is, and if you're getting numbers that are over 120, there are things that you can do in your lifestyle, like
Right.
quit smoking and get rid of the salt in your diet and start exercising that can help lower your blood pressure.
So I was sitting back and feeling pretty smug because, I'm over
That's
50.
who you are.
50s, and sometime over 50. So I figured that's a little bit easier, but that's not. You're not going to let me get away with it. All right, I'll shut up.
Definitely not.
And you shouldn't let your doctor say, "Oh, just take a pill, you'll be fine."
No.
You need to put a little skin in the
Well, I'm
game.
90 years old and I get up and I get dizzy from your pills. What do I do about that?
I mean, I think that's a discussion with your physician when you're that age and you have other medical problems. Maybe a higher blood pressure target is okay for you, but I think you should decide that with your individual physician.
Absolutely.
Right.
Absolutely.
Dr. Worden, welcome to Duluth. It's nice to have you here with us tonight. What causes hypertension?
What causes hypertension? I mean, I think it's multifactorial. It's caused by our genetic predisposition to hypertension for many people. It's caused by our high salt American diet, and obesity, are huge things, as well as kidney disease and things like that in our population of people. What else am I? Smoking.
Sometimes sleep apnea,
Sleep apnea.
yeah.
Yep.
thyroid issues. But most of the time it's
Lifestyle.
lifestyle.
Yeah.
So what can I do with lifestyle to keep my blood pressure down? Disha?
You can cook in your home with not using processed foods, so not eat out. You can get rid of the junk food and processed foods in your diet. You can exercise 30 minutes, just 30 minutes, go for a walk after dinner, and keep your weight in check. And if you are snoring a lot, this is a really great point that you brought up. If you're snoring a lot, or if you feel super exhausted during the daytime, it's really important to maybe just get screened for sleep apnea.
What about smoking? Is that helpful?
Oh, you gotta quit smoking.
So they have lots of studies on smoking, and that smoking elevates your blood pressure, and as you know, causes a lot of other negative health effects. And pretty much the moment you quit smoking, after that, your blood pressure and other factors of your health get better.
How about alcohol?
Yeah, excessive alcohol is also not good for your blood pressure. So more than 1 or 2 drinks a day for women, or 2 or 3 drinks a day for men, raises your blood pressure. So cutting down on alcohol can lower your blood pressure also.
That's right. And a drink is not 2 40s.
Right, yeah.
A drink is 1 12-ounce beer, 4 ounces of wine, 1 ounce
2
of
ounces
hard
of
liquor.
1 ounce
Yeah.
hard liquor.
2 ounces, 1 ounce.
So you shouldn't be happy with the heavy pour from the person that's
Not
bringing.
this one.
Right.
No.
All right.
You need to find a different bartender. That's what you're doing.
So we're going to jump a little bit. Disha, maybe this one's for you. What is angina? What causes it?
Angina is the classic definition of angina is pain in the middle of your chest caused by decreased blood flow to your heart muscle. So that can come on with exertion, so when you're walking around or running. It can also, we call it unstable angina if it's happening at rest.
So, Dr. Worden, tell me
Yeah.
about heart disease in women. The question has come in, what are the symptoms of MI in women or African American women?
Well, in women, people often think that women have atypical symptoms of heart disease or chest pain, which can be true, but women actually sometimes have very typical symptoms of chest pressure or tightness, pain going up into their neck or their arm, and nausea. But a lot of women also have atypical symptoms. I think that there's a problem in women presenting late, which is probably due to many different factors, and also a problem with us healthcare providers recognizing heart disease in women, basically. So we need to be more aware of heart disease in women, and women need to listen to the symptoms that they have and go to the doctor.
Mm-hmm.
There's been more discussion about Takotsubo heart.
Mm-hmm.
Any one of you want to take that on?
Sure.
Go ahead.
So Takotsubo is a problem with the heart that can happen after a person experiences a very stressful situation, such as the death of a family member or some other large event in their life. And it's thought to cause, kind of a temporary dilation of the heart, or the heart kind of dilating and not functioning well. And with good medical care from a cardiologist or some good other doctors, it gets better with medical treatment, and it's not due to blockages in your heart arteries.
Mm-hmm. We call it broken heart syndrome.
Yeah.
Mm-hmm.
And Japanese term from octopus pot. It's this big, looks like an octopus.
That's why it's called
yeah.
Takotsubo.
Takotsubo.
Yeah.
Japanese
That's
word.
what the heart looks
Right.
like when we look at it on
Angiogram.
in the angiogram.
Angiogram?
Yeah.
Do you see it on echo?
Yeah.
Yep.
You can totally see
Both
it on
places.
echo. Absolutely.
John, this lady from Duluth just didn't feel right. Her blood pressure in the ER was 188. She spent 4 hours in the emergency room. She didn't really feel like the emergency room visit helped her with much of anything. But any ideas what might have caused that 188 blood pressure and the way she felt? And it's really hard because we don't have the medical history and we don't have a lot of other things to go on here.
Well, I'd say two things. One, the ER is a really pretty stimulating environment even for people who are there every day. And so sometimes pressures in the ER are elevated, for lots of reasons. And usually when your blood pressure is elevated, frankly, you don't feel very good. Your body's not designed to operate at a blood pressure like that. So if that person, I'm not sure what happened to just speaking to you wherever you are out in the ether, that your blood pressure, it should not be that high, and you need to make sure you get that reevaluated. I'm not sure what happened in that ER visit. I certainly can't say, but I suspect the physicians there evaluated that pressure, probably took some steps to try to bring it down, but might have partially. Sometimes you look at the old records, perhaps the pressure was elevated in the past. Perhaps there's other reasons it was elevated from stress, or perhaps some other underlying conditions.
There's so many things that can raise blood pressure, especially in that setting, like you mentioned, anxiety and pain, fear, all those things can. But it's important to know what your blood pressure is at home on a regular basis, and to even maybe sometimes keep a log and show your doctor when you go and see them, so we can get a better idea of what your body's seeing on a regular basis.
And the explanation of just not feeling well might not have been from the blood pressure at all.
It's really hard to say.
So hard to say.
Yeah.
Yeah.
Unfortunately, that's not the
Yeah.
answer probably
Yes.
want, but that's probably truthful. Yeah.
Question, a person from Superior, Wisconsin, has been treated for 30 years for hypertension.
Mm-hmm.
Why would they begin to have issues with low blood pressure, hypotension, and presyncope off the medications?
When they're off the
Off the
medication?
medications. I'm not sure I understand this.
Well, I think a person who's been treated for hypertension for 30 years is probably a more elderly person, it sounds like, and possibly they have some other health things going on that are causing them some maybe autonomic dysfunction or something that is making them feel like they're going to pass out. It's hard to say without knowing more about the situation.
Yeah. It sounds like their pressures were low. They were on the regular meds, the pressures were low, so they tapered off the meds, and then there were other issues after that, and so perhaps there's some new underlying problems, or just the consequences of being older and on the same medication.
Yeah, unless your heart, there's hypertensive heart disease, and if you end up with a weak heart, then when somebody's heart can be really, really weak, then they can have lower blood pressures, but it's so hard to say unless you know the whole story.
Yeah.
Yeah.
What does longstanding hypertension do to the heart?
It thickens your heart walls, and it can make you have, diastolic heart failure or.
What's diastolic heart?
Sorry. Diastolic heart failure is when your heart has
You gotta educate me on this one a little bit.
stiffening and trouble with relaxation, and it can happen as a normal part of aging, and it can happen as a consequence of hypertension or, things like that. That's what I would say.
Any
And it's less well understood than
Yeah.
the
Yes.
typical is this, systolic heart failure where you just don't get the squeeze when you're pumping the blood out.
I'm
That's
still struggling to understand it. That's
right.
Yeah. None of us have the magic key for diastolic heart failure. There's nothing shown to reduce mortality for that.
Dr. Wood, I don't know the answer to this one, so
I'll rely on my
We'll see if
lifelines
these two
here.
have it, but
Yeah.
we'll probably have to do that. Can hypertension contribute to vision changes
Sure it can. Yeah.
and floaters?
Floaters. Certainly can fit.
The vision change, I understand.
Yeah, because you can get end artery damage with high blood pressure, and that obviously the retinal artery supplies blood flow to your eyes. You can get vision issues with that. So that's certainly understandable. The floater issue, I hope an ophthalmologist
Yes.
can
I know.
call
I
in.
was gonna say, my best friend's an ophthalmologist. Maybe I should call her. I don't know.
I think
I
the
don't know.
etiology of floaters probably isn't really very well understood anyway, so I would say no.
Ask your
I'm
eye
gonna-
doctor.
Yeah,
Ask
ask
your
the
eye
eye
doctor.
doctor. That's
Yeah.
right. Question again, probably it's a good one for you from Ashland. Lisinopril and cough. Is that a normal symptom?
It's not normal, but it's certainly a common symptom that's easily fixed when you stop the lisinopril. So
I remember percentages up 20 to 40%.
I thought it was 20%.
Yeah.
I usually
So it's
quote 50.
Really?
Half the
I was
patients,
coded
yeah,
20, but
yeah.
it's high. And so it's
Super
not a
high.
surprise, and it's easily solved.
So let's go to the big issue,
Oh,
aspirin. Who wants to
yes.
jump on aspirin?
We want to jump on aspirin.
Well,
Wanna
you
start?
brought it up, so
Okay.
go ahead and start the
All
discussion.
right, so we've gotten several calls in our office, and I've seen many patients in the clinic asking about whether or not they need to stop their aspirin. And so, you know, I'm in a cardiology office, and there was that new trial that came out. And the thing that I want everybody to know is that you need to talk to your doctor before you stop your aspirin if you've been prescribed it. And so it's really important, especially for my patients who have known coronary disease. So if you've had stents, if you've had bypass surgery, those patients should not stop their aspirin. That study that was published was not for you. It's irrelevant to you. And so I really want you to know, don't stop your aspirin without talking to your doctor, please.
So does taking aspirin, if you're normal, does that help you?
If you
don't have any
If you don't have any
Normal
cardiac
is-
disease?
I mean, I think we don't know for sure right now, but I'd say most recent evidence suggests that, you know, you may not need to take an aspirin if you don't have other medical problems already known.
John, how often does the aspirin cause GI problems, that 81 milligram thing?
Percentage-wise, I don't know, but it's certainly implicated. You know, often we see people come in with a GI bleed, they have taken aspirin. I can't quote you on that, Ray, but I would say it's certainly an issue. And so a lot of people with other underlying issues related perhaps to alcohol, maybe they have some issues anyway with gastritis or inflammation of the stomach for other reasons. Aspirin's just going to irritate all that, you know. And so percentage-wise, I don't know, but I'd say it's certainly something that you should not take if you've had a history of a GI bleed.
So when you prescribe it, how do you have them take it? With food? Is that generally what you do?
Yeah, and it's not really prescribing, it's more, you know what I mean?
Suggesting.
I guess, but yeah. And you know, we've gone the same way with the aspirin because it used to be a thing, you know, a few years ago, but now, like a lot of things, science gets a little better and realizes that it's perhaps not as beneficial as we thought. And in some cases, harmful, like you probably alluded to right there.
Depending on who you are.
Right, depending on who you are. If you're a
Yes.
heart patient, see.
Yeah.
Yes.
Yeah.
Yeah.
The word is out.
Okay,
Don't
good.
stop.
We feel better
Stop it
now.
without
Yeah,
talking
we
to your
can-
doctor,
yeah.
please.
So atrial fibrillation. Who wants to take on what atrial fibrillation is? That's the easy side if somebody wants to jump in.
Well, I guess I can talk about atrial fibrillation. So that is a heart rhythm problem where you have kind of irregular contractions or electrical signals from the top part of your heart on the left side. And the reason that physicians care about it and the reason we take it very seriously is because it puts our patients at risk for a stroke. And the risk of stroke with that heart rhythm is dependent on their other medical problems and their age and their gender. But we want to prevent strokes because it's the #1 cause of disability in the United States right now. So that's why we take it pretty serious.
Yep.
So can the person have atrial fibrillation and not take any medication for it?
The only person that we would maybe recommend not taking any medication as far as blood thinners would be someone who is extremely low risk based on different scoring systems that we use. But almost every patient we see in clinical practice has a number of risk factors that are going to make us recommend anticoagulation.
So I have an area of thin knowledge. Is there an area of the atrium where more of this comes from, and can that be blocked off in some way, the clotting? Is there a procedure for
As far as treating the atrial fibrillation or
no, for
preventing the clots?
well, both, as long
So
as you're
for-
going there.
yeah,
You're the
okay.
interventionalist.
I don't do either one of those procedures, but we think that atrial fibrillation may come from the pulmonary veins. That may be where it's generated from, which is in the back part of the left atrium, sending out kind of irregular signals. And electrophysiologists, which are electrical heart doctors, can do procedures sometimes to isolate those veins with catheters and special techniques and try to make atrial fibrillation go away. That procedure, as far as I'm aware, is about 70 to 80% successful. It's more successful if patients are able to get their diabetes under control, lose weight, treat their sleep apnea. So it's not like taking out a gallbladder. As far as the procedures to exclude the left atrial appendage, is what we would call
That's what I was
the
going for.
Watchman device. So those devices are mostly for people who have tried anticoagulation for their atrial fibrillation and have had some kind of problem. They have GI bleeding, they fall a lot, and they've had a bleed in their brain or something like that. And then a structural cardiologist may offer to put a plug in this little appendage in the top part of their left side of their heart. It's a pretty big procedure, and so it's not offered to everyone with atrial fibrillation.
Yeah.
That's what I would say.
Good answers. Hawthorn berries, John.
What?
Do they help blood
Hawthorn
pressure?
berries.
Or hawthorn berry tea?
I do not know. So I would say that if someone's drinking hawthorn berry tea, it might be suggestive of the fact that they're watching all the other things in their diet. So that's a good thing. The problem is a lot of this stuff hasn't been studied. You look at, say, red yeasted rice, or a lot of these things are proposed to be helpful and are helpful, but the problem is you have to take so much of it that it's really not helpful practically. So I can't really answer that question.
I agree.
Yeah.
Newer anticoagulants, are they worth switching to from warfarin? So Eliquis and all the others that are...
So I would say that if you're having no problems with your warfarin, and it's very easy for you to take, then there's probably not a reason to switch, but there are quite a few patients who love being on the new anticoagulants because it doesn't require any blood testing or monitoring. You don't have to watch what you're eating. You don't have to worry about antibiotics changing the levels of the blood thinning effects. And so it really depends on who you are if you're going to be a candidate for one of those. And again, you got to talk to your doctor about that.
Premature beats with a pacemaker in place, is this a problem?
It depends. I would say it depends. Neither one of us are electrical specialists, but I would say if you have extremely frequent premature beats, whether you have a pacemaker or not, it may be a completely benign thing, or it could be a problem. And I think if you feel those early beats or something like that, or another physician is concerned about the early heartbeats that you have, you should see a cardiologist.
Yeah, you should talk to your electrician of the heart who
Yes.
helped you with that pacemaker.
Right. Put
Yeah.
that in the first.
So we've been kind of walking around a lot of things. Let's kind of come together on a new one then. And what are the risk factors for congestive heart failure?
High blood pressure, diabetes, history of MI, history of heart attack in the past,
Smoking?
smoking, high cholesterol,
Alcohol?
alcohol. Yeah.
Yep.
All things that are actually pretty common. So put together, you can see why heart failure is a huge issue.
Yeah.
Mm-hmm.
It is.
Genetics?
Genetics. Yeah.
Genetics, sure. And now we even see it in some patients who've had cancer and who've had certain chemotherapies.
Oh,
Yeah.
Yes, that's been coming up and creeping up a little
Can
bit
that
more.
affect the valves too?
Absolutely.
Yes.
Radiation therapy can affect the valves, so we're seeing more and more patients with cancer and heart disease.
What is a bundle branch block? John?
Well, bundle branch block is. We got to look at this thing.
All right.
I
You
get to show the
asked for it. Bring out the model.
Our goal is not to have to drop this, but basically, you have the conduction system of the heart. The rhythm starts in the right atrium, travels down, bundle of His in the middle of the heart. And you've got two wires that come off and contract or send signals to each side of the heart. Right bundle and simply in the left bundle. Right bundle going
left
yeah.
bundle.
So bundle branch block would be a block that would slow that electrical conduction down through one of those bundles. And of the two, probably the left bundle is the more concerning because that goes to the left ventricle, which is the bigger muscle and the one that sends the blood to the body. Hope that answers the question.
No one's challenging. Okay. But it is wiring. What is the difference between Crestor and Lipitor, and then how do the statins work? It's kind of a double question.
So Crestor tends to be the more potent statin, and it works by blocking an enzyme called HMG-CoA reductase. And so it just blocks that enzyme. And so usually the Crestor, it's just more potent than the Lipitor is, which means it works a little bit more strongly at lower doses.
What was the other part of the question?
How do they work?
Oh.
Blocking that enzyme.
Oh, okay.
Yeah.
So you're using them, there's more and more the use has gotten wider and broader. You're using them more and more in diabetes, and anything that may lead into heart disease is more aggressively than we have in the
we
past.
consider diabetes a coronary artery disease equivalent disease, basically, and so we treat it very aggressively with cholesterol medication and blood pressure lowering.
You know what, actually, what I want to make sure that's clear, though, when we give Crestor or Lipitor to patients who have coronary disease and high cholesterol, it's not just about the cholesterol. It actually helps stabilize the crud that's in the arteries, and it helps stabilize it and keep it from flicking off downstream and causing a heart attack. So it reduces your risk of future heart attack, helps you live longer if you've already had a heart attack, and decreases hospitalization. So that's the other part of that.
30 seconds, John. How frequent should you have your blood pressure screened?
Screened? Oh, probably. There's guidelines out there. Certainly when you're over 40, you need to have it checked. If there's a family history, you need to have it checked much younger than that. Certainly every year as part of a sort of...
These wrist things work pretty good?
Well, the problem is the smaller the appendage you're checking, the less accurate the blood pressure. Yeah.
I want to thank our panelists, Dr. Disha Mookherjee, Dr. John Wood, and Dr. Nicole Worden. Well, this thing isn't working sometimes. And our student volunteers, Jacob Bentley, Casey Riley, and Alec Rudstrom. Thanks to all of our viewers and those who called in with questions. Please join Dr. Paula Turmulin next week for a program on women's health and female cancers, when her panelists will be Dr. Colleen Evans, Dr. Anna Perlshine, and Dr. Melissa Roby. Thank you so much for watching and calling in. Good night.